Two things. At the end of this week, I do need your remediation. If you haven't done it, make sure you've done that on the HESI NextGen tile, please.
Professor, did you just say only do the essential packets, not the recommended packets, correct?
Essential packets.
Okay.
You said you'll go in and grade it, right? We didn't have to try to take a picture.
No, I'm going to go in. I'm going to go in. And I'm just making sure, like I said, that you've done the work. Okay. Yesterday we had a staff meeting. There was a lot of talk about the HESI and the remediation and all of those pieces. And really, I think the messaging that we want to impart is that the HESI isn't just a check-off thing. The remediation isn't really just a check-off thing. The remediation is for you to understand the areas that you're weak in, right? Though that's what it's for. And for you to sort of take that information and let it percolate so that you can begin to develop some strengths in the areas that you're not so strong in. So I would take that seriously so that you can use that information. And even though it just says essential packets, it might be wise to do the recommended packets as well for your own knowledge base and just use that information because, you know, down the road, those types of questions may come up again. It's just for your benefit ultimately, so you can get in the mindset of passing your NCLEX, right? That's what we're trying to do.
I have another question in regards to the EAQ. When I see that it's set on 1 million, and so with that, it's a joke. It's set extremely, like, you know, for the questions to, I guess, go to intermediate, I think somebody said. Okay, but my question is, what if you only, because I didn't recognize it said intermediate. I noticed that when I did a couple of them, it just said novice. What does that mean? That means you didn't pass?
I'll have to have a look at it and see. The bottom line is week 1. So I'm really glad we're having a little bit of this conversation. I don't want to take up too much time about it this morning, but here's where I'm going with all of this. Term 4 is stepping it up a bit. Mm-hmm. So term 3 is more about, hey, you know, you need some hand holding, you're new, you don't know what you're doing, and all of those pieces. So we're going to hold your hand through that. And EAQs and things of that nature on the whole are set at novice. Term 4 is beginning to sort of push you a little bit, like an obstacle course, right? Where we're making those jumps a bit higher, all of those things. So this is what we're doing right now. So the EAQs, week 1, I have them set at novice, and week 2, we're going to intermediate and proficient.
Oh, okay.
That's where we're going. So please be aware of that. You know, again, you may not get 100 points in, you know, 100% in everything you do, and that's sort of unrealistic anyway, quite frankly, but do the best you can. I think some of these things you can go back and redo them, I think. No, that's the HESI one that you can do the best grade. The HESI ones are the best grade. All right. Now, it looks like some of you struggled with this quiz. Was it the questions, or was it the time, or what was it that you struggled with? 4 of you struggled. 4 of you struggled with this.
I needed time. I needed just a couple more minutes. That was it. And next time I'm going to just set my own timer so I know.
Yeah, I'm not sure why it didn't give you a. I don't know if it does. That's interesting.
Yeah.
I haven't run into anybody using all the time, and some people have made this like a asynchronous 20. You've got 24 hours to do this quiz. Take your time. as I say, all the quizzes are 5% of your grade, but I really wanted to get you guys in the mode of up and running and getting quizzes done, you know, because I sort of think you need it. And I think this indicates to me that you do need it. And, you know, as I say, I'll have one-on-ones with you and we'll discuss what happened. But I will also look to see if the dosage calc may have knocked some points off.
I think that's what it is.
Given. Feedback regarding the questions. Were the questions what you expected, or were they too hard, or what?
It's not, I was struggling on the one that right before I stopped. It was the question, it was the second to last question on the patient who was taking sertraline and also had alcoholism, had a history of alcoholism and a history of morphine. And it had all the different medicines. Should they have hydrocodone? So I was struggling on that one before I got timed out. And I'm trying to do it without using a book or do anything. So,
Okay.
so
Good.
I'm trying to think them through.
Yeah.
And
let me look at that one for you. Give me a second.
so I didn't even get to put in an answer, I don't think, because it shut it down. It was like it's shutting down.
And remember, these quizzes, by the way, not all of you have it in the same order. It tends to shuffle it. So I'm just looking to see what you were.
And I didn't even see the last question, so I don't know what that one. I don't know what that other question was, but.
Okay, it's higher. A hospitalized patient has history of depression. Patient has a morphine after surgery. Blah blah blah. Okay, so the rationale on this particular medication, and it's not an easy question. You know, we're looking at pain meds, and you will be looking at pain meds. Now, remember one thing, Dilaudid is a synthetic opioid, by the way. I don't know if you're aware of that, as opposed to morphine. It has less side effects, although it's 4 times as strong, which it is, if you weren't aware of that. It's actually a good choice because one, it's synthetic. It's very, very good for severe pain. And like I said to you, we never use Demerol, so you could rule that one out straight away. That's off the table.
I was more along the lines of the hydrocodone or the Tramadol. So Tramadol is kind of a, you know, that used to not even be a scheduled drug.
Right. And Tramadol really, I probably wouldn't use Tramadol. To me, that's not necessarily post-surgery where I would be going.
I would have chose hydrocodone plus the acetaminophen would have been my choice. Probably.
Right. And remember, you see, the big key here is the guy has a morphine allergy. So I don't know if you recall me talking about morphine and the fact that there are a lot of issues. A lot of people have issues with morphine. Dilaudid can be used because it's synthetic.
Okay. I would have chosen that.
Yeah, and that's not necessarily always the rationale, but I'm just letting you know how the critical thinking is. Morphine is not synthetic. Morphine is derived, of course, from the poppy, opium poppy, right? Whereas Dilaudid, with it being a synthetic version, tends to have less side effects, even though it's really strong, okay? But it's a very, very good post-op medication. Now, the other piece just to bear in mind is, you know, you've got your Lorcet, hydrocodone and Tylenol. Well, this guy has a history of alcoholism, so what are we thinking there? liver problems, right?
Mhm.
So we may not want to go with the Tylenol with that.
Okay.
So that's not an easy question.
No.
Not at all. And some of that, I'm just going to let you know what we are going to do is I want to say next week. I'm trying to make sure that you guys can have Miss Antonia Smith talk with you about test taking strategies. Okay, so you will have the opportunity to we will have like an hour. She'll go through questions, pick your brain, and help you sort of develop some test taking strategies as well. Okay.
You know, and even like because he had the history of alcoholism, I mean, and she'll tell us because we've talked to her before. Don't think about what you've seen on the outside. See, for me, what I would have seen, it would have either been the hydrocodone or the tramadol, and the tramadol to me is not. It might be addicting to some people, but you have to take I don't think it gives you that a pure feeling that the other medications do for somebody who has had a history of.
Right. I think there are a few variables in there, and I think ultimately what we're looking at is he had surgery.
Yeah.
So,
Okay.
We're looking at somebody who is post-op,
Post-op.
post-surgery. So you probably want to go for some, and I think it said he was in severe pain, or I can't remember.
Yeah. But he was in post-op, so it should have been the other drug.
Probably
that's what they give at post-op.
Yeah, you're going to look at something IV. You're going to look at something like, but as I say, just remember the morphine Dilaudid thing. Dilaudid is 4 times as strong.
Okay.
It's incredibly potent, but it's synthetic. Okay. So
you were tricky.
Not intentionally.
That was way above my pay grade right now, that question.
But you know what? Now you've been jump started, right?
Now I'll never get that wrong again.
Now you've got your adrenaline going. So, all right, guys. So we have a few hours here. I want to go through chapter 11, 12, and touch on 13. I think yesterday we pretty much did chapter 13, so I don't really feel that we need to go through all of it that much, but I do want to touch on some things. I will do a couple of questions with you from Silvestri, and I do want to, if we've got time, I'd like to do a couple of ABG questions as well. So without further ado, let's turn to chapter 11, please. And we're looking, first of all, I just want the physiology of the fact that you have various different ways that water or solutes move from intracellular to extracellular, okay? You've got body fluids and particles, solvents and solutes, and a lot of the time these solutes are called electrolytes, right? And so you've got different ways that they can move, and I touched on this yesterday. You've got filtration. So on page 161, it talks about filtration, and filtration is a pushing effect. Anybody have a filtration water system at home or anything like that, right? So you've actually got a more force that's pushing water through a filter to basically make that balance occur. And it's water molecules moving from a higher gradient to a lower gradient. That's what's going on there. So I just want you to be really more aware of that. We're not really going to have to do too much about it. But what's a clinical application of pressure, of pressure, for instance? Blood pressure, right? That's a clinical application of filtration. So blood pressure is an example of a hydrostatic filtering force. It moves whole blood from the heart to the capillaries. That's what it does. So guess what? If your heart isn't working effectively, that's when you're going to run into the issues such as congestive heart failure, edema, all of those pieces, right? That's what's going on. So we're going from high pressure to low pressure. So I just want you to be aware of that to create that balance. And like it says on page 162, edema forms with changes in hydrostatic pressure, and that's the differences between the blood and the interstitial fluids, such as in, like I just said, right-sided heart failure. And it just basically, again, talks about what I just said. When the heart is too weak to pump, you're going to get that backflow effect that goes on. And part of that backflow effect is edema that happens. Excess filtration from the capillaries into the interstitial tissue spaces then forms visible edema. So I would just make sure that you're aware of the clinical application of what filtration means. The water moves from high pressure to a lower pressure. And then you've got diffusion. So diffusion is slightly different. Diffusion on page 162 talks about the movement of the solutes, which is not the water this time, it's actually the particles. And as you can see on page 162, again, we're looking for that balance. We're always looking for homeostasis in the body, whether it's with ABGs or whether it's with fluids or whether it's with anything else. So diffusion is the movement of particles across a permeable membrane from an area of higher particles to lower particles. Again, the gradient is going downwards. And so how do we look at a clinical application of that, for instance? Well, so one of those examples is glucose. So we look down at the bottom of page 162, and it talks about the fact that some particles diffusion cannot occur without help. Well, glucose doesn't work in a vacuum. It needs help to go in and out of the cells, right? What helps glucose move? Any idea?
Fluid?
Insulin, right? That's part of the problem, yeah? Insulin builds up if you, I'm sorry, glucose builds up if you don't have insulin to transport it where it needs to go. So it talks about this right here at the bottom. Glucose cannot cross some cell membranes without the help of insulin. Insulin binds to insulin receptors on cell membranes, and then it makes it more permeable to glucose. So glucose crosses cell membranes with the help of insulin. And that's just an example of diffusion. You're looking at particles right there. We move on page 163, and it talks about osmosis. And again, osmosis is the movement of water, and it's the movement of water across a semi-permeable membrane. However, it says here, for osmosis to occur, a membrane must separate two fluid spaces, and one space has particles that cannot move through the membrane. And at the bottom of page 163, it's showing water molecules, and it's also showing particles. The particles are the little triangles, and the water molecules are the little blue things right there. And so what it's trying to say is, again, you're looking for that balance, right? So it's looking to make sure that there's a balance between the osmotic pressure, meaning, and I'm just going to use sodium as an example here, because it's not to do with making sure you've got the same amount of particles. It's making sure that the osmolarity is appropriate. And it talks a little bit about osmolarity on page 163. In order for the normal osmolarity in plasma to occur, you're looking at a range of 270 to 300. That's isotonic. That's your 0.9 normal saline. That's what we're looking for. So if you've got a fluid that is a higher osmolarity, let's say dextrose, something of that nature, then you're going to want more fluid in there to make it basically balanced again. If it's a lower osmolarity, then the fluid is going to shift out of there. Does that make sense a little bit? Okay.
Mhm.
So the reason I bring this up is it's talking about fluids with osmolarities greater than 300 are hypertonic, okay? They have a greater osmotic pull. So something that has a lot more osmosis to it, a lot more particles to it, a lot of what's the word I want? Try and think of it in a simplistic form. Thicker. I'm just going to use the word thicker. That's not exactly the right word, but it's going to pull water to it. All right. So it's hypertonic. The opposite occurs if you look further down. Fluids with osmolarities less than 270 are hypotonic. So they have less viscosity and all the rest of it to it. So the fluid is going to shift from that again. I want you to be aware, let's see, if a hypertonic fluid is infused into a patient, the infusing fluid would make the adult's blood hyperosmotic. To balance this situation, the interstitial fluid would be poured back into the circulation to dilute it, to dilute that blood osmolarity back to normal. So we use these fluids a lot of the time, the hypertonic fluids, if somebody's in shock, like septic shock, to help them balance out. That's one of the ways that you would create that, that shift. And a hypotonic fluid, so I just explained to you, like say 3% saline or something that has a high dextrose solution would be a hypertonic solution. And then something that is a hypotonic solution would be, say, quarter normal saline, rather half normal saline right there. Let's see, where do I want to go with this? So you can see that all of these things work together. Now, I want you to be aware of this. When a body, when an adult loses water, such as excessive sweating, the osmolarity is increased, right? Does that make sense? You've got less water there, but you've got more salt there. So it's more hypertonic going on in the body. That tells your body, wow, I've got a lot of salt on board. I need to drink some fluids. You get thirsty. And so you're trying to create that balance, yeah? So you're going to drink some water because you're in a hypertonic state. So I just want you to sort of think a little bit, and that might help you a little bit to understand that. All right, fluid balance. So I do want you to know your electrolytes. The ranges, for instance, are down the bottom. What's a sodium range?
130 to 145.
136 to 145. Okay. And tell me potassium.
3.5 to 5.0.
Yep, good job. All right. So definitely be aware of your ranges and know them. And it says about here as well on the bottom of 165, the minimum amount of urine per day needed to excrete toxic waste products is actually only 400 to 600 mils. That's not a lot of urine, I don't think. Not a lot of urine at all, right? A small amount, quite frankly. Does anybody know what insensible water loss means?
Something about thyroid?
Well, you know,
Isn't it sweating?
Yes, exactly.
Yeah, like thyroid to do with your either excessive sweating or somebody can't sweat at all, right?
No, insensible water loss is something like sweating because you can't really measure it, right? I could try and wring out after I've been to the gym and wring out my t-shirt and pour it into a cup maybe, but it's hard for me to really measure that, right? On the whole. So it's sort of that insensible loss. water losses from salivation or certain drains and things like that. Some of these things are insensible loss because we really don't have the mechanism to control it, and it's really difficult to measure it. But it does say in a healthy adult, the insensible water loss is about 400 to 1,000 mils a day. But you're right, Mimi. See what it says there? The loss increases if you've got something like thyroid crisis going on or burns, yeah? Those big blisters that can occur. So you can have a lot more insensible water loss in those extreme conditions, absolutely. All right, something I wanted to, all right. So question for you guys, this is an NCLEX question. If a patient's sodium level is 150, would you be concerned about that?
Yeah.
Yeah.
Yes.
Good. I'm
Because
glad
now
to
you're going to
hear
start
it.
retaining fluid.
Yeah. So their sodium level is 150. And let's see what it says here. It's saying that there are certain foods that the patient can consume. Peas, nuts, cheese, cauliflower, or processed oat, what are they? Processed oat cereals.
So cauliflower, or wait, yeah, I think
Out of all of those, are there any that the patient can take?
yeah, that the patient can eat. Yeah, the vegetable, right?
Mm-hmm. Peas and cauliflower because they're vegetables. Absolutely.
Not the peanuts because they have salt. Not that processed meat because they have cured salt. They have salt. And then I don't remember what else you said, but it was processed.
Yeah, peas, cauliflower, and let me just, well, that's crazy because they put, you can have nuts. Now, I wouldn't
Wow.
put nuts in there.
I
I'm so
wouldn't either.
surprised. But they did say nuts. So peas and cauliflower for sure. But you would not want processed food. You would not want cheese. Cheese is very high in fat and sodium as well. And I'm sort of surprised that they put nuts in there, that you can have nuts, but very interesting. But what it's saying about the nuts is as long as they're not canned, again with foods, you know, the vegetables, as long as they're not canned or as long as they're not processed or as long as they're not salted. So just to let you know, that's an NCLEX question. All right. So hormone regulation and fluid balance. So one of the biggest hormones that addresses fluid balance is to do with the kidneys. It's actually aldosterone, antidiuretic hormone, and natriuretic peptide, which is created in the brain, okay? So it talks about it right here at the bottom of 165, and it says aldosterone is secreted by the adrenal cortex. Where are your adrenals?
On top of your kidneys.
Thank you. Good job. You were listening last week. Yes. And so whenever sodium levels are low, aldosterone prevents water and sodium loss. It holds on to water, and therefore it's also going to hold on to sodium, okay? And so it reabsorbs sodium and water from the urine back into the bloodstream. That's what it does. And it helps that increase in blood osmolarity to occur. Antidiuretic hormone, or vasopressin, is released from the posterior pituitary gland, also in response to blood osmolarity. So just be aware of those two pieces. ADH works on the kidney nephrons. It's that whole feedback system that occurs. And again, you're going to get more water reabsorbed by the tubules, return to the blood, and therefore decreasing blood osmolarity and making things more dilute in the body. All right. Natriuretic peptides, and this is actually one of those important pieces to just bear in mind, because somebody with congestive heart failure, the way that a lot of the time they can tell if there's an issue is there'll be an elevation in their BNP. And BNP stands for brain natriuretic peptides. What happens is the natriuretic peptides or hormones, they're secreted by the atria natriuretic peptides and the ventricles in the heart. And for some reason, they're known as brain natriuretic peptides. I think there's a response to the brain with that. So I just want you to be aware of that, okay? BNP. So you might see that. You may see that elevation occurring in lab work, and that's one of those indicators that the problem is having congestive heart failure. At the bottom of page 166, it has a beautiful diagram about the renin-angiotensin pathway. And again, this is a feedback system. So this feedback system maintains blood volume, and we need it for what? Perfusion, and that's critical for life. So when the kidneys sense that, say, water or sodium is getting low, they begin to secrete renin. And then renin sets this whole wheels in motion to do with angiotensin 1 that then converts to angiotensin 2. And where have you heard about angiotensin before? Any idea where you may have heard about ACE before?
Yeah, diabetes.
Or where else?
Cardiac.
Yes, with blood pressure meds, right? ACE inhibitors. So what this ACE or angiotensin does when it's converted to angiotensin 2, it starts to increase blood volume and blood pressure. And how does it do that? It's a constrictor. It's a vasoconstrictor. And so it constricts arteries and veins through the body. And it talks about it right there on page 167. It constricts the size of the arterioles that feed the nephrons, and therefore you're going to get a lower glomerular filtration rate, a reduction in urine output, and it's going to help to what? Raise blood pressure. That's what it's doing. That's great when we want it to work like that, but what do? We give ACE inhibitors, right? Because people that have high blood pressure, we want to inhibit this action right here. So I just want you to be aware of how this works, this whole process. It says here as well, at the bottom, I'm not at the bottom, I'm sorry, of the little paragraph that I'm looking at about angiotensin, it talks about decreasing urine output, that prevents further water loss, more is retained in the blood, that also helps to raise blood pressure. And it also causes the adrenal glands to secrete what? Aldosterone. We just talked about that, right? And what does aldosterone do? That also saves water and sodium as well. So all of these pieces put together, this whole renin-angiotensin pathway and aldosterone working together helps to raise blood pressure and helps with perfusion that we want throughout the body. And why is this important? Below here, it talks about a clinical application where you might see that working, right? Somebody's in shock. Those are the pieces that go into action, right? That's why your urine output drops when somebody's in shock. So that's why we're sort of very, very much aware post-operatively or anything that's going on with the patient, we're always looking at that urine output because that's one of the indicators that perfusion could be low in the body. And again, it's talking about what I just talked about, ACE inhibitors. So if somebody has high blood pressure, we want to inhibit this whole action, and that's what it talks about there. There's other blood pressure medications that we can use. Another class is called ARBs, right? We can use ARBs instead of ACE inhibitors. ARBs are actually better for Afro-American population ACE inhibitors are actually not very good for Afro-American populations. Calcium channel blockers are actually best, by the way. But it talks about it right there. It says another class of drugs used to manage hypertension is the angiotensin receptor blockers. Again, they're blocking that pathway so that those arterioles can't constrict. So just want you to be aware of that. All right, dehydration at the top of page 167. So, you have a question? Nope. No.
We're stretching, sorry.
Oh, it's okay. If you need to stretch anytime, please, please do. That's a good thing. At the bottom of page 167, look at many of the causes of fluid imbalances and look at all the massive causes there of dehydration. There are a lot of situations where a patient can be dehydrated, right? And it talks about this as well. It says dehydration may occur with just water fluid loss or with fluid loss and electrolytes. Okay, and we already explained what electrolytes are. Yeah, those are all your particles in your body. And it talks about the fact that circulating blood volume is decreased what? Hypovolemia. And that, again, causes reduced perfusion. So just want you to be aware of those pieces right there. And what I want you to do is turn to page 168 because now we get into the fun stuff, the stuff that we do. So look at page 168 and where it says assessment and it says noticing. So Amber, yesterday one of your concerns was asking about intake and output. And we also have to look at the fact that many patients do not know that solid foods contain liquids, right? Other foods such as ice cream, gelatin, ices are liquid of body temperature and are included when calculating body temperature. I'm sorry, when we calculated fluid intake. So I just want you to be aware of that. I don't think you're going to get a test question that says, you know, please calculate how much gelatin that patient has as an INO, but I want you to be aware of it in your practice, okay? All right, so collect specific information about exact intake and output volumes and daily weights. Why is daily weight important? Well, it says it right here. Weight loss is an indication of dehydration. 1 liter of water weighs 2.2 pounds. So changes in daily weight are the best indicator of fluid losses or gains. A weight change of 1 pound corresponds to a fluid volume change of 500 cc's. So when we're looking at our congestive heart failure patient, that's one of our teaching tools, isn't it? Hey, Mr. Jones, I really need you to weigh yourself every day at the same time so that you can let us know whether you're gaining weight, which could correlate to an issue with your congestive heart failure. All right? So be aware of those things. On page 168, it talks about physical signs and symptoms that help us evaluate dehydration. So can anybody tell me what one of those could be? It's on page 168.
What was, I'm sorry, you said tell you what, which is one what?
A sign and symptom of dehydration.
Oh, well, I wasn't gonna read it, but I guess I can. I was gonna just say that dizziness. I was gonna say that dry mucous membranes. I was gonna say like when people have dry mouth or whatever. Also their skin. But I wasn't. I can read.
Down the bottom there, it says it. Look, skin turgor, right?
That's it.
Yeah, pinching the skin. And what is it that we called it? We called it what? When you pinch it. And, thank you. You got it. Yeah, exactly. Exactly. So with dehydration, their neck veins are flat. even when the patient, you know, their neck veins don't necessarily raise, they're not nice and puffy, they're flat. That's another thing. Hypotension is another thing to be aware of as well. Like you just said, dizziness, those types of things, those changes. Pulses can get weak and thready. Why? Because we don't have that perfusion going on in the body. It all goes back to the perfusion and the heart being able to pump what it needs to pump around the body. Does that make sense?
Yes, ma'am.
Yeah, makes sense. So you've got, I'm just looking at it here. I can see at least 1, 2, 3, 4, five different issues at least that are great indicators of, oh my gosh, my patient is dehydrated. The fifth one that I'm looking at right here is kidney changes. And what I just talked about, right? If you're seeing a fluid deficit, if you're seeing urinary output dropping, if you're seeing the color, it says it right here, dark amber color or a strong odor, those could absolutely indicate that we've got some kidney problems and that we've got some severe dehydration going on, right? And of course, that doesn't help with kidney perfusion and all of those concerns that can go on as well. All right, on page 169, it says best practices, and I love these little cheat sheets, as I like to call them, because it talks about what you're going to do as a nurse for your patient. Best practice for patient safety and quality care. And it talks about some of the things that you're going to do as a nurse for your patient to help with treating that dehydration or preventing dehydration. Can anybody name a couple of them in there for me?
Preventing dehydration?
Well, it says the patient with dehydration. What are you going to do? What are your interventions?
You give them fluid whenever possible. You try to push fluid. If they can't take stuff NPO, then that's, I think it was the time for you to ask the doctor, can they give an IV or whatever. But you just want to make sure that you are pushing fluids at all costs, even if they don't like water. Okay, well, if you might want to put a little lemon in there or something. But there's things that you can do to try to get them to drink ice chips, or you know, if you want to give them a popsicle or whatever like that, or whatever, just try to get some electrolytes inside them. Good. Gatorade and stuff like that.
At the bottom of 169, I think this is a really important thing to be aware of. Can anybody see at the bottom of 169? It says teach your UAPs to offer 60 to 120 mils of fluid every hour to your dehydrated patients. Very easily for old people to get dehydrated, isn't it?
So in the nursing home, Professor, they have the water pitchers or whatever, or now they don't even do the water pitchers anymore because of sanitary issues or whatever. We do cups, and you fill the cup full of ice, and this is how you know when the shift is really when the CNAs is doing their job or not. When I go in there and I'm getting ready to get the medication and I'm out of water on my cart, I'm supposed to be able to go in there and they got a cup of ice water. Every shift they're supposed to issue a cup of ice water or whatever. But what I've noticed that in the nursing home, even if the CNA does or doesn't have the ice water in there, the resident's not going to drink it. Like, you put it in there for them to drink, but they're not drinking it. So I have a mechanism now that I buy popsicles. I used to buy popsicles and put them in the freezer on the unit, and then just pass out, if they didn't have diabetes, of course, pass out popsicles once a shift or whatever, and give them an incentive to make them get the liquid inside them, because they weren't doing, like, they will not pick up a cup and drink a cup of water.
Well, you know what, me on that end, you know, the CNAs, they just don't have the initiative to actually give them the cup, offer them fluid. They don't offer it. They just sit it down and walk away. That's it.
Yep. So you're right. I was a CNA too, so you're absolutely right. You're right.
So let me just bring this around, because I want to bring this down. Here's the thing it says right here: instruct them to take the time to stay with the patient while they drink the fluid and note the amount. Okay, it's not appropriate to withhold fluids, and in a way that's sort of what's happening, right? If we're not doing that piece of it. So, and remember, the RN, Caitlin is already one, yeah. So it's appropriate for us to be at that level where we take responsibility for that, even if we're not doing it. It's like, hey, Jenny, did you make sure that Mrs. Smith had her cups of fluid? You know, we have to be the ones to push that initiative, okay? All right, so I think we sort of talked a little bit about hydration and what we should be doing. And Mimi, you did touch on the fact as well that we, of course, are looking at IV fluid. So on page 170, down the bottom there, it does talk, there's just like a little table 1114, that just shows the different fluids, and it shows you whether they are what's called isotonic, which is your, 0.9 saline, hypotonic, which is half normal saline, and then the others, a lot of them are hypertonic, for instance, predominantly those with dextrose. They're your type of, your hypertonic type of fluids. So let's go on to 171, and you can see a nice little picture there of what's called pitting edema. Has anybody seen pitting edema before? You know what I'm talking about? You basically stick your finger and it stays.
Went out in it, but I think you're saying edema, but you were frozen.
Oh, pitting edema.
Mm-hmm.
Yeah. On page 171. So basically this is fluid overload. You've got too much fluid on board. And, that's another big indication that you've got some cardiovascular problems going on. It could be a GI issue, but basically there's too much fluid in the system in that particular space, right? At the bottom of that, just on the bottom of page 171, can you see the little cheat sheet, little flow diagram where it says increased extracellular fluid? So what does extracellular fluid mean?
Outside the cell.
Thank you. Just want you to be aware. And it's explaining that this is usually as a result of circulatory overload, which it is, right? And like I mentioned to you earlier, one of the lab values that you might see is an increased secretion of natriuretic peptide from the right atrium, or as you will see it, BNP. You will see BNP rise. On page 172, again, our favorite bit is what we do, right? The things that we're going to be doing and what we're going to be looking at and how we're going to be evaluating that patient. It says it right here, patient safety is the first priority. And there's a whole lot of issues, right? There's a whole lot of problems that we can see. One of them, of course, is the opposite to what we see with dehydration. We might see an increased pulse rate. We're going to see bounding. We might see veins that are engorged. We're going to see elevated pressure. We're going to see weight gain. Respiratory wise, how's that going to affect your patient? Anybody have a clue?
They can't breathe.
Shortness
Yeah.
of breath, yeah.
Right? They're overloaded. Too much fluid on the lungs, right? Infiltrates in the lungs, those types of things. Crackles. You might hear crackles when you acetate. Again, they may have altered level of consciousness, just like dehydration, but it's affecting them differently as well. They may as well have skin breakdown, because with edema, if you've seen real edema, it can be very taut, very tight. So they're at high risk for skin breakdown. So please be aware of those things, especially over the coccyx, the elbows, the hips, all of those areas, the heels. And so what are our UAPs going to be doing?
Monitoring their, what do you mean? Like checking their vitals?
Well, for their skin.
Oh, well, they need to make sure that they moisturize it. Like when they get them out of the shower, they need to make sure that they dry their feet. They need to make sure that they actually putting some lotion on them.
Smooth.
Yeah. You say keep it smooth?
What if they can't move?
Oh, then they need to reposition.
Thank you. Yes.
Constantly. There's no pressure ulcers or no bed sores and all of that. They constantly need to.
Right. A couple of medications that we use, diuretics, right? What are, anybody name a diuretic for me?
Lasix.
Yep, good job.
40 milligrams, standard.
What's one of the problems with Lasix, by the way?
Other than it gives you a headache, other than it makes you dizzy, other than like what you mean?
Well, one of the big problems, it's not potassium sparing, is it?
Right.
So you have to watch that potassium, whereas spironolactone is a potassium sparing diuretic. So just be aware of that.
Spironolactone?
Spironolactone.
Oh.
Spironolactone is a potassium sparing diuretic. So with that in mind, I have another question for you. I do, actually. Uh-oh. So we said we knew what the level of potassium is supposed to be. So if we have a potassium level of 2.5, is that an issue?
Yeah.
Yeah, it is. It's a big issue. And down at the bottom here, it says we're going to look for EKG changes, all right? Electrocardiogram changes, especially when your sodium is out of range and when your potassium is out of range. So it's something very much to be aware of. And I'm not going to go into it right now, a bit further in, but please be aware that there's going to be some EKG changes, and that could be things like, oh, let me just have a look. It can absolutely affect the U waves. It can affect what is called T waves, and it can also affect the ST segment in the EKG. So you may see some big changes in that EKG as a result of this potassium. What about a patient who has a sodium of 130? Is that the problem?
Yeah, it's low.
Very low, very, very low. And that could be because they're taking diuretics, possibly. Could be, right? So just be aware of that. All right, so where do I want to go with this? Your patient that is overloaded, we talked about the fact that we're going to restrict their sodium. Why would we restrict their sodium?
Because sodium it absorbs fluid. The sodium is what's sucking the fluid out of them. So you want to make sure that you don't give them anything with fluid. I mean, with a lot of sodium in it, because you don't want the cells to shrivel up and keep blood sucking, for lack of a better term.
You don't want it pulling it to it. Wherever sodium goes, water goes. All right. So if you've got a high sodium content, this is osmosis. This is what osmosis is. Wherever sodium goes, water goes. Okay. So we want to restrict that sodium. It says right here to about 2 grams to 4 grams of sodium a day, so that they don't get too much water being poured with it. So yes, you're right, Mimi. Okay, so that's something to be aware of. You're going to monitor those INOs really, really carefully, right? You're going to, again, check the urine. You're going to be aware of fluid retention. And we already said some of the ways that you're going to tell with that is looking at their weight gain. And what did we say that, we said that each pound of weight gained equals what? Anybody remember? And if you don't, it's on page 102.
One what?
Each.
Isn't it 1
2
liter
pounds.
equals 2.2 pounds?
Right. So what's 1 pound? About 500 mils. Yeah. So each extra pound of weight is about 500 mils.
Yeah, maybe Sunday or Saturday.
Hey, Kaylin, I'm going to mute you.
Oh, sorry.
All right. Okay, so please be aware of the daily weights, and you're absolutely right. It says right here, instruct the patient to call the healthcare provider for more than a 3 pound gain of weight in 1 week or a 2 pound gain in 24 hours. So please be aware of that. It's pretty important, especially for your CHF patients. All right, moving on. Electrolyte imbalances. So How are you going to know whether there's an electrolyte imbalance if you don't know what your electrolyte levels are? So please be aware, like we talked about ad nauseum. We already said what sodium is. We already said at the bottom here, it looks foods with the highest sodium levels are those that are processed, pickled, smoked, all the good stuff. You know what I like? People are going to go, ew, how can you eat that? I eat pickled herring. Anybody else like pickled herring?
What is herring?
It's a fish, pickled fish.
Oh.
Yeah,
I never heard of that.
my husband.
I'm not gonna say ill because I like pickles, so I ain't gonna say ill.
My husband, look at Kaylin's face. People look at, I mean, you know, I love pickled herring. I absolutely love it. But anyway, just one of those things. I could eat a whole jar of it.
It got a pickerish taste to it, or
Pickers.
Yeah, I mean,
stop it.
I think it's an acquired taste. I mean, it tastes sort of salty-ish, like pickled food, but it's definitely an acquired taste, but it's something I grew up on. So anyway, my husband always looks at me like, what are you eating? But pickled herring. Anyway, that's an aside. What did I want to talk about? Let's see.
That every adult is that is ill has a risk for electrolyte imbalance. I don't think I agree with that. I think everybody is at risk for an electrolyte imbalance.
I think we are. You know, this is why we don't take in enough water, nowhere near enough. Should be drinking
Right.
about 2 to 3 liters a day of water, at least, and we don't. So it says it right here, in case I need to say it again, where sodium goes, water follows, all right? So bear that in mind, please. Foods lowest in sodium include fresh fish, not pickled fish, and poultry, and most vegetables and fruit. And it does talk again about what we talked about, the renin-angiotensin system, and how sodium balance is regulated by the kidneys, and the influences, like we talked about, aldosterone, ADH, and natriuretic peptide, okay? Hyponatremia. So what is hyponatremia?
Decrease.
Low sodium.
Low sodium.
Hyponatremia.
Low sodium.
Yes. Sodium. And I think we've beaten that dead horse already, right? So we know that that would be anything below 136. So you're aware of that. And we've already established that, like that NCLEX question just said, if somebody is on diuretics, a common cause of low sodium levels is the prolonged use and overuse of diuretics, especially in the older adult. So please be aware of that. And it's going to say the signs and symptoms of hyponatremia are caused by its effects on the excitable cellular activity. And so if we turn over to page 174, we have, I'm looking at least 1, 2, 3, 4, at least 4 big changes that you're going to see with your hyponatremic patient. There's a table at the top of 174, but can somebody give me a couple of ideas of what you might see on your hyponatremic patient? Don't all shout at once.
Excessive sweating.
Okay, yes, absolutely. It says that right at the top.
Mhm.
What else well, that's a cause, Amber, but what might you see with your patient? But yes, you may see excessive sweating, absolutely. What type of changes might you see in your patient that has a low sodium? There's, below the table, there's italic sections that show the different changes that you might see with your patient that has a low sodium.
Oh, rapid, thready pulse. That's weak.
Yep. A rapid, weak, thready pulse.
And diarrhea
hypotension.
and abdominal cramping.
Yeah. Yep. Bowel sounds are hyperactive. Bowel movements are frequent and watery. So we're going to, unfortunately, that's going to create even more hyponatremia, right? What about cognitive changes? Anybody? Can anybody see any cognitive changes? How about confusion? And you may also see diminished reflexes as well, just to let you know. So please be aware of those pieces that you can see, as well as the causes, right? So anything that maybe, if we've got a lot of drainage occurring with our patient or things like that, anything that's going to, like it says, diuretics, wound drainage, especially GI, an NG tube may cause it. They've got a lot of drainage from there, things of that nature. So what are we going to do for it? Well, we're going to replace that sodium. So it could be that we need IV, right? You might need something like a hypertonic saline, but you have to be really, really careful with that. It says most often 3% saline. That would be for somebody who's severely hyponatremic. Very, very severely. But anyway, I just want you to be aware of that. But really, we're going to just replace that fluid and replace some of that sodium. They may use something like, just normal saline, something of that nature, an osmotic one. All right, hypernatremia. So what does hypernatremia mean?
High sodium.
High sodium.
Yes. How high would it be to be caused high? What would be the level?
Above 145.
You got it. Good, good, good. All right. So turning to page 175, what types of, well, first of all, at the top there's a little table. It says excess sodium. So some of the things that could cause excess sodium are what? Anybody? You're retaining sodium.
It could be that you have a fever.
Okay, yeah, absolutely.
I don't understand how diarrhea plays a factor in that, but according to that chart,
because you're losing water, but you're retaining the sodium, maybe.
Of it. Oh, okay.
Yeah. Mm-hmm.
Okay.
Steroids can do it.
Nothing by mouth. Yeah.
Mm-hmm. Yep, kidney failure.
Definitely steroids.
Well, you think about steroids have so many negative feedback systems within the body that they're, I'd have to look up the mechanism of action, but they're absolutely steroids could do it. Especially you think about what happens with steroids. You get Cushing syndrome, right? With steroids, where you retain water, but again, what did we say? Where water goes, sodium goes. So if you're retaining that water, you're probably retaining that sodium too. All right. So how does that affect the body? It says, I can see several of them right here. The nervous system.
Your heart.
Yeah, absolutely. It says again, hypotension can be caused there. You might have the pulse rate is the opposite to what's going on with hyponatremia. You might have a higher pulse rate, okay? Increased pulse rate, those types of things. Skeletal muscle changes, you might see muscle twitching, contractions, those types of things. I've seen those types of things occur. And again, you might see cognitive changes as well. All right. So again, what are we going to do? Well, looks like we're going to give some fluids. And in this time, we might just actually give the half normal saline rather than the just pure isotonic saline. It might need something that's actually going to pull out that sodium a little bit. And we're really going to treat the root cause as well. So it could be if they've got kidney failure, we're going to look at that. They may need dialysis, might need something like that. Potassium. All right, potassium level, we already mentioned the range for potassium. But be aware, it says almost all foods contain potassium. What are some of the things that are high in potassium?
Crackers.
Banana.
Meat.
Meat? Yeah.
All processed foods. Like when people think that I'm going to get a Lunchable, oh baby, them Lunchables contain some sodium. Or any frozen foods contain sodium, has a lot of sodium in it. Like those ready to eat meals, like, oh, I'm gonna go get me a lean cuisine. Yeah, okay. Look at that sodium content.
Right. So with potassium, so if we're going to start talking about potassium. So what types of foods would you think that might be high in potassium?
Yeah.
Banana.
Bananas. Yeah.
Potatoes.
Yeah, actually you're right.
Fish.
Yeah. Yeah. It says here meat, fish, and many vegetables and fruits and things of that nature. So yeah. All right. It's funny. It says it's lowest in eggs, bread, and cereals. All right. Now, hypokalemia down at the bottom of page 175. What does it say right there? If your potassium goes below 3.5, what does it say?
Life-threatening.
Yes,
Life-threatening.
indeed. Yep. It reduces the excitability of the cells. And so at the top of page 176, it talks about the different things that can cause potassium changes or hypokalemia. But what are we going to notice about our patients? What are some of the things that we might see with a low potassium? Look at the bottom of 176, the italic areas. I can see at least 5 different things.
Already a weak pulse. They have a weak pulse.
Respiratory, musculoskeleton, cardio.
Yes, and Rhonda, you're right. They could have a weak pulse. It could be a very rapid pulse, irregular pulse, absolutely. Musculoskeletal changes, right? They may get paralysis of some neurological changes, again, all of the same sort of stuff. Look at the gut changes, very different from sodium, right? The complete opposite. Hypoactive bowel cells, decreased peristalsis, which is actually the opposite to what we were seeing with sodium.
Mhm.
Okay. So at the bottom of page 176, can you see where it's looking there in the yellow, where it says potassium is given IV for hypokalemia? And we talked about this yesterday. And there is a lovely little chart on page 177 about the patient with hypokalemia and best practices, right? It talks about the fact that you would never get, well, first of all, you would never give IV potassium IV push. That just never happens unless you want to kill your patient. That's not happening. Okay. It talks about as well what the infusion rate should be. Can anybody tell me what it says there?
2 milligrams. Wait. Yeah.
Not faster than 5 to 10 MEQs
Per what?
per hour.
Wow.
Yeah. So you got to make sure you're doing that slowly. Look a little bit further down. I want you to see where it talks about the EKG. And the reason I bring that up is because it's one of your questions in your NCLEX questions, by the way. And it talks about looking at the EKG of somebody with a low potassium, with hypokalemia. And look at all the different things that can occur. The heart rate is low, less than 60 beats per minute. You've got.
Are we still in the chart?
I'm
Yeah.
sorry?
It's just at the
We're
bottom
still in
of
that
the chart.
box?
Yeah, all in that box in chart 11.5. It talks about wide QRSs. It talks about the PR intervals are prolonged, T waves at all. Now, I'm not saying that you need to know these things right now. I don't think that that's an expectation, but I just want you to be aware of how much it affects the heart, okay? So what are we going to do? We could give IV potassium. We can also give oral potassium as well. Those lovely big horse pills that we give to our patients, right? The 40 MEQ of potassium orally. It can also be given liquids, but it says here potassium has a strong, unpleasant taste. I'm sure it does. All right.
Why they say don't crush it?
Yeah. One of the other things I want you to be aware of, like we talked about, is Lasix. It is not potassium sparing. So again, you can lower your potassium as a result of taking Lasix. And it does talk about spironolactone there, which is a potassium sparing one, all right? Talks at the bottom here about not only looking at some of these other changes that occur, but one of the big is respiratory monitoring as well. So some of the things that can occur with your patient that has hypokalemia is their SATs go down and their respiratory rate goes down. So just be aware of those things there. All right, page 178, hyperkalemia. What would hyperkalemia be?
Higher than 5.
Yeah. Yeah. So you can see it's a fairly narrow window, right? 3.5 to 5. That's not a big window. Very narrow. I would say when you've got a narrow window, a lab value, those are your more toxic ones, right? So just bear that in mind. So hyperkalemia, so you've got increased cell excitability. So the opposite things are going to happen. So at the bottom of page 178, it shows the common causes of hyperkalemia, what can happen. But I do want you to be aware of some of the symptoms that the patient's going to have. So what might you see? Or what might your patient tell you?
They might, I mean, I see something that says bolus IV potassium injections. That makes me think that, remember when we were talking about how when people give the IVs, they talk about it's burning or something like that? Is that related?
It is, but what I'm asking you, and maybe I didn't word it well, is when you walk in and your patient says, my heart is twitching, or I've got palpitations, or some of the other things, and it's halfway down on page 178. There's about 3 big things right there, and the biggest one is cardiovascular that I'm looking at, and I'm like, I wonder if their potassium's high. Now, I'm not just going to be thinking that, but what might you see, or what might the patient say to you is going on with them?
Their
Numbness
stomach,
in your hands and feet.
Mm-hmm.
The diarrhea.
Yeah, absolutely. What about, they may have muscle twitching, and they may say, you know, my heart's I've got palpitations, or it's skipping a beat, things like that. They may have neuromuscular changes. You know, they can go into complete heart block. They can go into asystole very easily with any of these ranges, with hypokalemia, hyperkalemia. So, as I say, again, it says here, cardiovascular changes are the most severe problems from hyperkalemia and the most common cause of death in patients with hyperkalemia. It's a big deal. So if you've got a potassium higher than 5, you better be getting hold of your healthcare provider, okay? And starting to do something about it, because you're going to see changes really quickly with that patient.
I was about to say, well, you talking about us as the nurse, or are you talking about them as the patient? Because they wouldn't know that.
But if your patient is coming to you and saying, my heart's racing or whatever, you know, first of all, you're going to do an EKG. And as it says it right here, EKG changes of tall peaked T waves prolonged PR intervals, flat or absent P waves on wide QRS complexes, and ectopic beats, all of that you might see, and that might trigger you to go, whoa, let's get a stat potassium lab. Now you're going to do other things, but I'm just helping you to put some of the pieces together, that's all, okay? Because it's causing excitability of the heart cells. That's what it's doing. It's making the heart excitable. All right, so, and it does cause things like diarrhea. Everything is excitable, right? So it's going to cause increased motility. And it says right here, I just want you to be aware of this critical rescue. Assess anyone who is at risk for hyperkalemia and recognize cardiac changes. So if their heart rate starts falling, or if they've got high T waves on an EKG, you're going to call rapid response. Okay, so just be aware of those things. And then it could be that we have to give them medications that bind the potassium. Kayexalate is one of them. You may remember that. There's it says a newer approved drug to treat hyperkalemia is patiromer, which I'm not so familiar with. I'm more familiar with Kayexalate. But anyway, the other thing we can do, it says increasing potassium excretion helps reduce hyperkalemia. So potassium excreting diuretics, that's something that we could do. We can also do another thing as well. Insulin, sometimes they'll use insulin because insulin increases the activity of the sodium potassium pumps. So it moves potassium from the extracellular fluid to the intracellular fluid. So I just want you to be aware. It says IV fluids containing glucose and insulin are prescribed to help decrease serum potassium levels. So you may see them actually go ahead and prescribe insulin and also dextrose to help reduce potassium as well. So don't be surprised if you see that. Just wanted you to be aware of that. And of course, you're going to monitor your patient. You're going to do cardiac monitoring with this patient. Let's see, what else do I want to go on to? Oh, I want to go on to calcium. Calcium, this is a fun one. And we're nearly finished. And then I'll give you a 15-minute break and we'll do the next chapter. All right, so calcium. Lovely, lovely calcium. So let me just see, what is the calcium level?
9.
Nine to what?
Is it like 10.6?
10.5.
10.5, yeah.
Yep.
10.5.
Yeah. So remember what I said about potassium and narrow window? Look at how narrow calcium is, right? Pretty narrow. So you're going to see big changes with your patient very quickly. And I find this really interesting because I have seen this myself. So calcium is it's an excitability type of electrolyte. So I want you to be aware of this, and you can see that that range is very, very low. And it says right here, because the normal blood level of calcium is so low, any change in calcium level has major effects on function, which it does. So first of all, I'm just going to talk about the fact that, where do I want to go with this? This particular mineral. It says this mineral is important for maintaining bone strength and density, activating enzymes, allowing skeletal and cardiac muscle contraction, controlling nerve impulse transmission, and allowing blood clotting. And it does, Miss Phlebotomist. I'm sure you saw calcium in your tubes, didn't you, Evelyn? Yeah, yeah. They would put calcium citrate in the tubes for blood clotting. There you go. Is that right? I think that's right. Yeah. All right. So, of course, what helps calcium move? Vitamin D. Vitamin D helps calcium move. And I want you to be aware of that. The two go together very closely. And that's why you have vitamin D in milk, by the way, because it aids the transportation of calcium. That's why vitamin D is so important. And they're actually doing studies that recognize that vitamin D, they really look at vitamin D now more as a pro-hormone than a vitamin, just FYI, because it has a hormonal effect. It's used in that way. Calcium is stored in bones. When more calcium is needed, the parathyroid hormone, PTH, is released from the parathyroid glands. And PTH increases serum calcium levels in different ways. And it talks about it right there. It releases calcium from the bone storage sites. It stimulates vitamin D. It inhibits calcium excretion, and it stimulates resorption. And I'm bringing this out for a reason. The next thing I want you to be aware of is the effect with calcium in the thyroid glands and the parathyroids. It says right here, when excess calcium is present in plasma, PTH secretion is inhibited, and the secretion of thyrocalcitonin, which is a hormone secreted by the thyroid gland, is increased. Now, I don't necessarily need you to remember all of that, but I just want you to be aware of the synergy between the parathyroids and the thyroid glands and calcium, and this is important in a minute. Hypocalcemia, how are you going to notice that? Well, one of the things at the bottom of page 179, it says acute hypocalcemia results in the rapid onset of life-threatening symptoms, and it does. I've seen it. One indicator of hypocalcemia is the report of muscle spasms, Charlie horses in the calf. You know, when someone says they've got a Charlie horse, you ever heard that expression? They get those and everything spasms and they can't move. I've actually had that. You ever had that? Or you just be like, oh
yeah, it's horrible.
Yeah, please let that pass. There's nothing you can do. You are actually immobilized, right? Until it passes. Yeah. Probably low calcium, just FYI. Sometimes magnesium as well can do that. But the reason I'm bringing this out is on page 180. Thyroid surgery, and this is a real biggie, guys. Thyroid surgery, therapeutic irradiation of the head or neck area, an anterior neck surgery, anterior is the front of the neck, increases the risk of hypocalcemia. Okay. When I was probably, I don't know, 21, and I was working on a med-surg floor. It was a surgery floor, and one of the things we did was thyroidectomies. So I'm assessing my patient, and I noticed she did this, not even with the blood pressure cuff. It's called Trousseau sign. It's a form of tetany. Tetany occurs with hypocalcemia. I was actually going to do, I was doing a blood pressure, and she said, I can't move my hands, but it's a classic sign, and it shows it right here. You will see it. What had occurred is it wasn't just a thyroidectomy, they'd taken her parathyroids as well. As a result, she went into life-threatening hypocalcemia. And these are the types of things that if you don't know how to notice this, you're not going to save your patient. All right? I'm just lucky, really, because it certainly wasn't because I was a brilliant nurse. It was just, I was like, whoa, I've not seen that before. That looks different. Hey, charge nurse, this patient's going into tetany, which she was, all right? So as it talks about right here, neuromuscular signs are one of the big things that you might see with your hypocalcemic patient. And I want you to be aware of that. Trousseau sign is what I just described to you. And you don't necessarily need to do the blood pressure cuff to see it. But if you're putting your blood pressure cuff on and you see that, then there's some hypocalcemia going. The other thing as well is you're going to do this to their cheek, and you'll see this severe muscle twitching going on. That is, it says here, is called Chekhov sign. Okay, so, and I don't know if I'm pronouncing it correctly. But anyway, I do want you to be aware of those. Those are big things that you might see. So your thyroidectomy type of patients that you may be aware of could be a partial thyroidectomy, not a full thyroidectomy. But if they are by chance have taken the parathyroids, then or cut the parathyroids or something of that nature, then you may see something like this occur. So please be aware of that. And if once you've seen it, you will never forget it. You'll never forget it. Anyway, of course, cardiovascular changes, you're going to see those. And it says right here, severe hypocalcemia causes severe hypotension and EKG changes, intestinal changes, increased peristaltic activity, hyperactive bowel sounds, and then it talks about, I'm going to say more of a chronic hypocalcemia. This isn't your acute situation that I was just talking about, but your chronic situation can cause things like what? Especially with your postmenopausal women. Any
osteoporosis.
Thank you. Good job, Mimi. Appreciate it.
Okay.
So what are we going to do? Well, we're going to give calcium. Yep, that's what we're going to give to our patients on one way or another, direct replacement of calcium. And of course, vitamin D, because I just said to you, vitamin D, it works like insulin, right, with glucose. It helps with that transportation. So it's the same thing. Vitamin D helps to upregulate the calcium. So we can give calcium-rich foods. If it's somebody who's chronic hypocalcemia, we can give medications, all of those different things that we need to give. Hypercalcemia, well, the big thing that can go on there, it shows right here, this is a life-threatening situation as well. Severe or prolonged calcium imbalance depresses the electrical conduction and slows the heart down. So you can get asystole really quickly with that patient. All right. And you have to be careful, because what if you're replacing your calcium on your hypocalcemic patient and then you overshoot and then you go the other way and cause hypercalcemia? So be aware of that, because it says hypocalcemia causes excitable tissues to be less sensitive to normal stimuli. And so you can have the opposite effect going on here. So let's see what it says. Assess for slowed or impaired perfusion, neuromuscular changes. The patient can be confused. It could have maybe muscle weakness. So instead of this sort of the twitching going on, you've got a lot of weakness going on, all right? And then decreased peristalsis, which again is the opposite to the other one. So it talks about certain therapies that we can do. We're going to stop therapies that have calcium in them and stop medications that have calcium in them. And we're going to restore the balance as well by giving things like normal saline. We may need to give chelators. Chelators bind things. You can get potassium chelators like Kayexalate, and you can get calcium chelators as well, which help to bind calcium, all right? And then, of course, drugs to prevent hypercalcemia, that prevent calcium resorption. It talks about some of them there, like your biphosphonates, those types of medications as well. And of course, you're going to do cardiac monitoring. Magnesium. Okay, if you didn't know, I love magnesium. It's one of my favorite things. Love it, love it, love it. It's such a wonderful thing to use.
They think that that's like a one-all be-all. I swear, they gave me magnesium for migraines. I was like, seriously?
Did it help you? No?
No.
Maybe they didn't.
Magnesium, Botox at the same time? Nope.
Migraines are one of those things that it's so many different factors go into it, right? So many different factors. All right. Again, magnesium has a fairly narrow index, right? It says it right here. Your hypomagnesium, again, things that are going to pull magnesium out of the body. On page 182, some of the causes of magnesium, of low magnesium. Anybody give me some idea?
Malnutrition.
Yep. Yep. Starvation, those types of things.
Celiac
Diarrhea.
disease.
Yeah, exactly. Certain medications, a lot of meds can lower the mag. So what have we got going on here? Hypomagnesia is caused by an increased membrane excitability, and it also can relate to sodium potassium imbalances as well. So cardiovascular changes, again, you're going to see low mag levels. It says here low mag levels increase the risk for hypertension, atherosclerosis, hypertrophic left ventricle, which is basically thickening of the ventricle, and dysrhythmias. You can get some real sort of serious, like defib can occur, AFib can occur. So magnesium, when that's lower, it's basically going to cause more excitability to the heart. Neuromuscular changes. You can also see that Charlie horse and the Trousseau sign and the Chekhov sign that we talked about. This can also happen with low magnesium because again, everything's getting more excitable. All right. And intestinal changes as well. But in this case, you're going to see lower motility, and you could also get a paralytic ileus as well. So please be aware of those. So we replace it with mag, right? Mag sulfate. Did you know there's about 4 different types of magnesium, by the way? It's quite a lot of different types of mag. What's one of the magnesiums that you use a lot for constipation? Anybody know?
Milk of mag?
Yeah, mag citrate, yeah, as well. Milk of magnesia, mag citrate. But some of the other types of magnesium that I like,
Citrate?
mag citrate is one really more for constipation, but the magnesiums that I like, that you may not see so much here, magnesium threonate is one, and maybe your problem, Mimi, is that they weren't using the right type of magnesium. Because seriously, there are magnesium threonate, which I love, gets up into the blood-brain barrier. I use it a lot for lots of different patients. I use it to help people sleep, along with some of the other types of magnesium, not citrate. And it has a very calming effect on the body. So it wouldn't surprise me that they use the wrong type of magnesium, just saying. You know, it can happen.
Go back. Okay, there's 4 types. Give me another of the 3.
Ask them what type of magnesium it is. So, you know, we'll look at that. Anyway, final point, and then I'll give you guys a break and then we'll meet back. Hypermagnesium. So too much magnesium on board, right? Again, you can see cardiac changes, but it's going to be the opposite. It's going to be that bradycardia effect. So just want you to be aware of that. It's going to cause hypotension. Again, you're going to see, possibly if you're not careful, what can bradycardia cause eventually?
Death.
Yes. Yeah. Your heart is going to slow down enough that you can go into cardiac arrest, right? And hypotension. So it says right here, severe hypermagnesia, too much magnesium, too much of anything, right? Grave danger of cardiac arrest. And again, lethargy, drowsiness, neuromuscular changes, everything is getting weaker, And you know, again, you can actually cause weakness of the diaphragm, and the patient can go into respiratory distress, right? So just be aware of those things. All right, that was a heavy topic, right? Big, heavy topic, but interesting. So why don't I give you guys a 15-minute break, and then we'll go on to another heavy topic, which is acid-base balance, and we'll be done. How's that? Any questions? You want a quick break, bathroom break, all that sort of good stuff? I'll meet you back. All right, stop recording. Try and stop recording.